I'm one of the orthopedic surgeons at North Tees Hospital. I'm just going to take you through quickly this ankle ligament instability, which is quite a common clinical condition that I see in my practice. So most of us, whether drunk or non-drunk, we have gone over our ankles. It's a very common condition, and it is one of the most common presentation in the A&E with regards to the ankle injuries. Both acute and chronic chronic injuries are seen, and it leads to a lot of other problems such as pain, dysfunction, and loss of recreational activities as a consequence of that. So if you look at the quick anatomy of the ankle, like the other joints that we've been describing, it is a complex articulation. It's made by three bones, the tibia, fibula, and the talus in the middle. And it's not a very stable joint per se, and hence it relies on all the ligaments surrounding the ankle. So there are many ligaments on the medial aspect of the ankle, there are ligaments on the lateral aspect of the ankles, and there are some muscles around the ankle which hold the stability. If you look into the general anatomy, the syndesmotic area is the other area which is very important, and that holds the tibia and fibula together. So not only the ankle is stable mediolaterally, but it has to be stable in the other planes as well. So there are mainly three ligaments on the outside of the ankle, and there's one big ligament on the medial side of the ankle. Now the medial side, as you all know, is something called deltoid ligament, and on the lateral side there are three ligaments, and one of the common that is damaged is something called ATFL, which is the anterior talofibular ligament. There's also a ligament between the calcaneum and the fibula, which is quite strong, but once you start getting the stretch injury to the ankle, it can also rupture. So if you look at the stabilizers of the ankle, they are static stabilizers, which is the shape of the bone, the ligaments surrounding, etc. But there are dynamic stabilizers, which are the muscles around the ankle. So the whole of these stabilizers will normally hold the stability of the ankle. So how do we go over on it? We could go over on it either just walking simply, or we can come off the curb, or high sporting injuries. Any of these injuries can lead to an inversion stress, as described in that little picture down there. I don't know if everybody can see it, but it actually leads to a lot of inversion stress, that thereby leading to stretch on the lateral part of the ligaments. That's the most common mechanism. So the acute sprains that come to A&E, they constitute mostly in younger patients, although we see quite a lot of older patients also getting these injuries. A simple coming off the curb or getting out of the car and you go over on it, and patients get injuries with that. Out of most of the injuries around the ankle, the majority of them lie on the lateral side of the ankle. There's only a small percentage on the medial side of the ankle. Unfortunately, not all of them settle. About 70% of them settle with time, but 20 to 30% go into something called chronic laxity. So what happens in a chronic laxity? The ligament that is normally present in a good tension doesn't heal up in good tension. So there is elongation of the ligament. Once there is an elongation of any collagen tissue, there's a loss of properties in that. It leads to deformation, and it leads to further recurrent injuries. So imagine yourself with a nicely taut ligament. Once it's ruptured, it heals up all right, but it heals up with a little lax tissue, and then you go over on it again, and that repetitive stress becomes a recurrent injury. So how do they present? And this is the most important thing that one has to understand, a difference between a functional instability and mechanical instability or anatomical instability. Now one would ask, what's the difference between instability and laxity? Now instability is like a symptomatic laxity of a joint, if you like. But in ankle, there are two different varieties that I see. One is called functional, which a patient comes to me and says, my ankle feels weak, I can't run, I keep going over on the ankle. But that doesn't necessarily mean they have anatomical instability or mechanical instability, which is characterized by the examination technique. So patients who have functional instability could be having some excessive laxity in their ligaments, but they're still complaining about it. but the mechanical are the one, when I examine them, they show signs of instability. So how do we evaluate these patients? We take the full history from the patient. We like to know what is the mechanism of injury, see if it's a chronic injury, and if that is the case, whether they complain of popping out sensation, whether they feel unstable when they run, whether they can walk properly, and if they can get swelling in these conditions. So when they initially come, they all look like that. They're all very swollen. But the acute injuries tend to settle down with time. But the chronic injuries usually have this type of swelling all along. And when you hence feel them, where I'm feeling now is the level of the anterior talofibular ligament, which is the most common ligament that is damaged. So you feel the lateral aspect of the ankle over the fibula and go along the fibula, along that sort of direction, and you feel the rest of the ligaments. And then after that, you move the joint and see how the joint moves. Now, normally the ankle is pretty mobile, but if there is reduction of the range of movement, then you possibly think that there is something not right. Then we come on to the special test to confirm. Now, the special tests are important tests which will find out if and which ligament is damaged. So the commonest that we do, like in the knee, is something called anterior draw sign, where you exert pressure on that part of the heel to pull the heel forward. So if the heel comes more forward than normal, you obviously compare it with the other side and make sure that that is excessive. And if that is excessive, that indicates the lateral ligament injury, particularly the anterior talofibular ligament. The other test that we use is something called inversion stress here. So you literally put the ankle into inversion stress and see how much movement that happens. And if that is an excessive movement compared to the other side, that indicates the calcaneofibular ligament injury. Some other tests such as squeeze test, where you squeeze the calf and the patient points the pain in the syndesmotic area, is very characteristic of syndesmosis. And you can also do an external rotation test. So when the patient is sitting, you externally rotate the foot, and if the patient complains of pain in the syndesmotic area, that is usually a suspicion of that. So we then grade them clinically if they are stage 1, 2, and 3, depending on the severity. So simple stage 1 could be just one ligament, and stage 3 could be a gross ligamentous laxity. Of course, we have to confirm the clinical findings by doing some X-rays, and the gold standard is still the MRI scan. Once upon a time, a few years ago, stress views were functional. We don't tend to do it anymore because of the advent of the MRI scan. Now, if we are treating an acute instability, then usually they are best treated conservatively. So we give them rest, we give them painkillers, we protect their walking, give them functional rehabilitation, and start early range of motion. And physio plays a significant role in the initial stage. They go on to do peroneal strengthening, they do proprioception, gastrosoleus stretching and strengthening, and then go on to the physiotherapy wobble board type of scenario where they get the better proprioception. But return to sport depends on how much is the damage. So if they are grade 1, they can return to sport earlier, as opposed to stage 3, where the return to sports may have to be discussed with the patient and of course with the physio. But generally, my experience is that return to sports is around 3 months. What if they fail to respond? They tend to go in the chronic laxity. This is the situation where you can still treat the patient non-operatively by giving them orthoses, or you can ask them to just simply avoid the sport which caused the problem, or consider the targeted physiotherapy. Now, if not, if they don't settle, let's say by the end of 6 months, that's probably the end point to the physiotherapy sessions, and we then after that recommend surgery. So who do we offer surgery to? Now, the patients who go into chronic laxity will have recurrent injuries, so they will keep getting the symptoms of instability all the time. So one day they might be absolutely fine, 3 days later they may go over on it, and then they will have a short period of acute instability again. So these are the patients where we offer surgery. Now, the surgery is broadly divided into 2 groups. One is something called anatomic repair, as the name suggests, we simply repair the ligaments, or something called non-anatomic repair, where we have to augment that with something else. And they both can be done both arthroscopically or open. However, it's now necessary, almost necessary, to do an arthroscopy for all these patients, because there are a lot of other things that are happening inside the joint that you cannot do it otherwise. So we found that most of the patients with ankle ligament injuries will have some intra-articular pathology. And likes of loose bodies, you can see a lot of cartilage damage, you can have an osteophyte, which is like a spur of bone, and that's why it is important to add that procedure. So like Adil showed earlier on, it has taken a lot of interest in arthroscopy of the ankle, but the setup is slightly different. We have to put a traction device like a hip device, and the foot is in this kind of a stirrup where we have to distract the joint and then protect the nerve that goes on the side of the ankle. And there are various portals. Then the portals are described as either onto the front of the ankle or to the back of the ankle. So you can, depending on which ligaments you're repairing, you can either go to the front or the back and then augment that procedure. And generally we do a normal examination and then go on to find other findings, such as the osteophytes or loose bodies, or ligament which is thickened, or chondral flaps and things like that. So when we discuss about the repairs, the anatomical repair, like I said, is the most common, where we just simply go and repair the ligament. Where non-anatomic, which is not so commonly used nowadays, is something that we keep discussing with the patient if the anatomic fails. So direct repair is something called the prostrum, which is the commonest thing that we do, and that is just simply done by repairing the ligaments back to the fibula, but we use some bony anchor sutures so that the repair is much, much better. In the recent times, that I have seen something called an internal brace, which is a fantastic augmentation device which acts like a tightrope, which has 2 screws on either side and has an augmentation tape. So in addition to your repair, you can augment that by putting this device called internal brace. The advantage of that is the rehabilitation is much faster, and I now don't almost put these patients into plaster at all. They go in a boot right from the word go, and 2 weeks, 3 weeks later they start physio, and then return to sports is much, much faster. So this is how the traditional brostrum looks, and the brostrum can be done either arthroscopic assisted, or you can do an all-inside procedure as well. And this is how the syndesmotic repair is done, by using something called a tightrope technique. This is the non-anatomic repair, which I was mentioning, by using the peroneal tendons, but it's not very good because of the associated complications of it, like stiffness and tendon problems, and hence we rely mostly on the augmentation technique. Post-op therapy is much faster. Like I said, I put them into an air cast boot right from the beginning, and the physio starts at 4 to 6 weeks with early return to sports, and they have absolutely fantastic outcomes if they are treated in time. Now, my general experience is I've taken 100 patients between these 3 years, it's just random 100 patients, and we've done about 80 of those with standard prostrum repair and 20 with augmentation, and we've done the audit on that. At the moment, the results are still full awaited, but we found 4 failures in these, and those 4 failures were incomplete pain relief, and their return to sports was not in time, and they had to have something done again. However, compared to all of these 100 patients, 4 failures is pretty good outcome as far as I'm concerned. What if they are left alone? They will lead to chronic problems, they will lead to osteoarthritis, they will lead to pain and disability. Most of these patients don't return to their pre-injury status, and then the secondary problem leads to osteoarthritis of the ankle, leading more open procedures and even osteotomies around the bone. So in summary, this is a very, very common condition. You will see more if your eyes see it, and your mind knows this, you will pick more and more of these. You do need a high index of suspicion as to when you call it as an acute, when you call it as a chronic, and because of the imaging techniques and surgical outcomes, we can very well provide future problems with this. Thank you very much for your